Welcome everyone, and thank you for joining our webinar today. My name is Suzanne Walker, and I'm the Senior Marketing Manager for Public Health here at Jones & Bartlett Learning. I'm here today with Anthony Santella, editor of the new book, Master of Public Health Competencies, a Case Study Approach, along with John Beard, Kim Curtis, and Christopher Wickman, who are three contributors to the text. Collectively, they're going to show us how they use public health case studies in their Masters of Public Health courses. So now let me introduce you to our four presenters today. First, we have Anthony Santella. He's an Associate Professor of Public Health at Hofstra University, and he's the editor of the book, as we discussed earlier. We also have Kim Curtis, who's Director of the Masters of Public Health Initiatives at the School of Public Health and Health Professions at the University of Buffalo. Then we have Christopher Wickman, who is an Assistant Professor of Biostatistics at the College of Public Health, University of Nebraska Medical Center. And finally, John Beard, who's an Assistant Professor of Public Health at Brigham Young University. And now I'd like to turn our presentation over to Anthony to get us started. Anthony?
Thanks, Suzanne. And thanks everyone for joining us today. It's nice to see we have, almost 200 people on the webinar right now. Before we get started, I just wanted to thank Suzanne and all her colleagues at Jones & Bartlett. This has been a very productive relationship that began about a year and a half ago at the APHA conference. And I had been, as a public health faculty member, looking for quite some time for some really good, realistic public health practice case studies. And my searches really were unsuccessful. And so after a lot of back and forth with the Jones & Bartlett staff, this project was born. And while myself, Kim, Chris, and John are here today, we really represent the 50 different contributors to this text. And so with that, I'll get started. So as is not probably new to most of you, we value in our profession case studies. Case studies present realistic, complex, contextually rich situations and scenarios that often involve some kind of problem, conflict, or dilemma. They can be used in any discipline, including any one of the core disciplines of public health, whether we're talking about epidemiology, biostatistics, social behavioral sciences, health policy and management, or environmental and occupational health. They also have common elements, and you'll see that across the cases that the four of us discuss in a few minutes. And you'll see that the format of them is consistent, where there's a description of the problem, there's a case study, there's application to one or more of the CEIF competencies, and summary points and discussion questions. More importantly, case studies allow students to develop skills in analytical thinking, reflective judgment, by reading and discussing these real-life scenarios with their classmates and instructors. Next slide. As we know, case studies vary in length and detail, although ours are pretty consistent in this book. They can be used in a whole range of classes, and I'll talk about that towards the end. Those of you who registered for the webinar, we asked you some questions, and I'll kind of go over some themes from those later on. These are all real public health case studies drawn from actual people and circumstances that have happened all across the U.S. They provide relevant data needed to facilitate discussion and resolve a problem, either all of the problem, the entire problem, or just some aspects of it. They require students to examine multiple aspects of a problem, and they could also help facilitate students kind of thinking in bigger picture terms about proposed solutions. Next slide. There are several advantages to using case studies, and those include what you see listed here: promoting problem solving, figuring out what you should do in a complex situation, coping with ambiguities, partnerships, facilitating partnerships and discussions between students and then between student and teacher, answering kind of difficult questions and opening questions not only of how but why certain things should happen, and provide students to really kind of walk around a problem and see the perspectives that may be offered by their classmates and or instructors. And most importantly, it allows us as public health faculty to bring in public health practice into the classroom. So what we're going to do now is we're going to run through 4 different select case studies from the textbook. I'll begin and then I'll pass it on to my colleagues. The first case is titled Oral Rapid HIV Testing in University Dental Clinics in Metro New York, and it was co-authored by Gwen Cohen-Brown, who's a dentist, a practicing dentist and a professor of dental hygiene at the New York City College of Technology. Next slide. So by way of background, there are over 1 million people living with HIV in the United States. And of this group, an estimated 15% are unaware of their HIV status. And so they may be unknowingly transmitting the virus to other people. So, HIV testing, we all know, is an important both public health and biomedical strategy used to lessen and hopefully end the epidemic someday. It provides an opportunity for those living with HIV to be linked to HIV care and treatment. It facilitates this concept of U equals U, or undetectable equals untransmittable, which means that someone who's taking their HIV medication as prescribed can achieve something called an undetectable viral load, very little to no virus in their blood, which means they can't sexually pass on the virus to other people. It also allows us to decide which prevention tools and technologies best meet the needs of our patients, our clients, including things like condoms or pre-exposure prophylaxis, which is the FDA-approved HIV prevention pill. Next slide. Dentists and hygienists who are already conducting oral exams and routinely do kind of chairside screening tests for oral cancer and things like hypertension. We also so they're already doing chairside screenings. We also know that a large proportion of Americans regularly go to the dentist each year but don't engage in primary care or regular primary care. We also know through research done by my work group and others around the country that dental providers are knowledgeable about HIV and when asked are generally willing to conduct HIV screening in a dental clinic. We also know that the evidence base supports that dental patients are also willing to receive oral rapid HIV testing in the dental clinic. So this is a good scenario where we have both providers willing to provide a new chairside screening and dental patients willing to receive it. Next slide. So what we did in 3 different public university-based dental clinics in the Metro New York City area is we implemented rapid HIV testing in dental clinics. Each site included a dentist, multiple hygienists, dental hygiene students, and was supported by an interprofessional team of public health professionals, including researchers, practitioners, public health students, and local health departments. This interprofessional team planned the study, and then the dental faculty and students at the 3 sites implemented it. And so the planning included development of the study protocol, design of data collection forms, securing the supplies needed, which included the actual test kits and refrigerators for the controls, getting institutional review board approval, training staff on things related to public health aspects of HIV, like the epidemiology of HIV, best practices in HIV prevention, and those sorts of things. Next slide. You can see here just what the test kit that we use. There are many different manufacturers of rapid HIV tests. We use the OraQuick Advance, which you can see is the size of a finger basically, and the applicator gets swabs the top gum, the bottom gum. It goes into a solution for 20 minutes, and then you read it like what you see on the bottom of the slide. The C line stands for control, the T line stands for test. So a positive or reactive test, both lines appear, like you see number A. The middle one is non-reactive or negative because only the control line appears. And then if the control line doesn't appear, which is what you see in number C or letter C, that means the test is invalid and would need to be repeated. Next slide, please. So what we did was, we planned the study, and then we, recruited patients from the 3 dental clinics by placing recruitment flyers in the reception areas on the designated days where the study staff was conducting the rapid HIV testing. The study staff then provided patients who said they were interested. They went through the consent process, and then they were brought to a private area where the oral swab took place. 20 minutes later, the study staff read the result. And in our case, because this was under a level of scrutiny because it was a part of a research study, a second person always did a reading before test results were read back to the patient and discussed with them. The participants then completed a brief questionnaire that captured information that you see listed there. Over a period of about a year, although it wasn't a consecutive year because of the start and ends of clinics being open and closed related to school schedules or university calendars, we tested 231 patients across the 3 sites. All received negative HIV tests. 2 had to be redone because their initial tests proved to be were indeterminate, or that letter C from the previous slide. So while we wanted to use this opportunity to see if the dental setting isn't truly an untapped venue to find people who are unaware of their HIV status, we were mostly doing this to look at feasibility of actually incorporating it into the busy dental clinic schedules. Next slide. So you can see from just a small snapshot that I provided you now that an interprofessional approach is needed to successfully implement these sort of public health interventions, particularly those that use biomedical technologies like the rapid HIV tests. Dentists and hygienists need a deep understanding of all the public health content, including epidemiology, surveillance, and policies needed to address clinical issues in a very comprehensive way. And that, dentists and hygienists are becoming more comfortable with this idea, although there's, as you can imagine, there's still some resistance when something is new and added to an already busy provider schedule. And while this is something that we hope to expand nationally, there is some debate around the scope of practice, whether dentists and hygienists as licensed professionals should be doing this. And in our particular state of New York, the Department of Education, which is what licenses the dental providers, versus the state health department, have conflicting views on whether this is within the scope of practice for dental professionals. So that's something we're still working out. Next slide. More importantly, you can see how this may relate to CEIF competency number 21, perform effectively in interprofessional teams. I'm keeping this brief for sake of time, but a lot of work went into developing and fostering the interprofessional relationship and collaboration between the providers and the public health practitioners. And while this may appear to sound easy and straightforward, there were several challenges, nothing that we couldn't overcome, but there definitely were challenges in bringing these 2 groups that traditionally haven't worked together to work together and execute this research project. And so there are things that we're doing, which you can see on the last slide, to try to facilitate better interprofessional relationships in the medical dental setting. Next slide. So public health professionals can also, bridge the gaps between providers and facilitate collaborations, not only within the dental field, but other clinical fields, everything from audiology to speech language hearing sciences, dentistry, medicine, etc. And so in addition to HIV testing dental setting, there might be other areas, and there are other areas where we've had successful interprofessional collaborations, like with fluoridation and Head Start programs and kind of meeting the oral health needs of special needs and people living with disabilities. So as a kind of a newer and emerging field or subfield of dentistry, public health dentistry is really where we see these 2 worlds collide. We'd like to now see this from a public health lens and incorporate more dental public health into public health curricula as well. Next slide. And then these are just some discussion questions which could be used to facilitate broader thinking in the classroom between student and faculty. And you can see here they include things like, how can public health professionals reach clinicians outside of academic institutions to change their needs of their profession? So this gives you a sense of where the conversation could go. So what I'd like to do now is pass the baton over to Kim to talk about our next case study.
Thanks, Anthony. So today I'll share a case study of a coordinated multi-sectoral response to the opioid crisis in Erie County, New York, overdose region. And this case study was co-authored by Dr. Gail Burstein, who is Commissioner of Health for the Erie County Department of Health. Next slide. First, some background. Erie County is on the western edge of New York State, which is shown by the red star on the map. And this is the opposite end of the state from New York City. It's also home to Buffalo, which is the state's second largest city. In 2015, the county medical examiner began to notice a significant rise in opioid-related deaths. And we can see this more than doubling, the mortality rate doubling between 2014 and 2015 on the graph. Additionally, in Erie County, fentanyl was the fastest growing cause of death that the Department of Health had identified, and law enforcement officers were continuing to find more fentanyl and more heroin throughout the county during this time. Next slide. The epidemic was affecting urban, rural, and suburban communities and individuals of all backgrounds. Buffalo was built on steel and manufacturing industries, and similar to other cities on the Great Lakes, it has a large working class population, and this contributes to very high rates of disability, inpatient and outpatient surgeries, as well as painkiller prescriptions in the region. So to address this crisis, in 2013, the state implemented a prescription monitoring program called iStop to track and report on controlled substances. Yet during this time, in Erie County, street supplies of heroin, overdoses, as well as opioid-related deaths were continuing to rise. Next slide. In 2016, County Executive Mark Poloncarz established an opiate epidemic task force, which was co-led by the Commissioner of Health and the Commissioner of Mental Health. And it included stakeholders from multiple sectors of society: police and courts, schools, the healthcare delivery system, community and family members, and nonprofit organizations, among many others. And they had a mission to diffuse best practices throughout the county, to provide support for addiction, and to deliver community-based prevention and treatment programs. Next slide. The task force consisted of 7 committees, and each had a different leader, a different set of priorities, and different representatives from constituent groups. So for example, the first blue box on the screen, the REAP committee, was led by law enforcement who connected individuals from police stations directly into treatment programs. The next box, the family support committee, was led by a parent advocate who had lost a child to overdose, and they prioritized community events. The committees for provider education and policy reform, hospitals and emergency departments, and treatment providers addressed healthcare delivery at policy and practice levels. The task force committees delivered programs through many different venues, as you can see on the slide, through hospitals, clinics, churches, fire halls, and government agencies. And what we can see from this framework that the task force created is a comprehensive strategy with reinforcing and consistent efforts. They really tried to leave no stone unturned. Next slide. And their efforts ultimately contributed to reduce opioid-related deaths in 2017, a decrease for the first time since 2012 in the county. In addition, preliminary mortality rates for 2018 also show a further decline. However, we're still awaiting final data from the county from last year. Next slide. So summing up the case, the county recognized significant increases in opioid-related deaths, and they created a task force to respond. The task force included multiple sectors of society that prioritized prevention, treatment, education, and policy reform, and they were empowered through a collaborative framework to act in a comprehensive and a coordinated way. And in 2017, for the first time since 2012, opioid-related deaths decreased, essentially reversing the trend. Next slide. So now let's look at the CEIF competency of systems thinking and apply it to this case. Systems thinking is the ability to see the multiple causes and effects of factors that are within a system and changes within that system over time. By applying systems thinking tools such as stock and flow maps and feedback loops, we can see causes which might not be readily apparent and hotspots for interventions that might not be otherwise considered. The opioid system in Erie County produces high mortality. It's a high mortality system. So we want to find ways to push that system backwards to reduce mortality. And we start by looking at what's accumulating. And we start with what we know. Well, we know that prescribed opioids are accumulating. And we know this because the state recognized it in 2013 when they implemented iStop. So we'll start there, with prescribed opioids accumulating in the bold box. We also will show factors that contribute to this accumulation, such as the prescription rate in the healthcare delivery system. And we draw these boxes and we gain this knowledge, again, based on what we know was happening in the county at the time. We know the region had higher rates of disability and surgeries, so lots of people were seeking pain relief from their healthcare providers. Next, we'll build out the stock and flow map further so we can see the pathway from prescribed opioids to high mortality. Again, we look at what's accumulating, and accumulations are represented by boxes that are on the map. As prescribed opioids accumulate, so does addiction, and with more people experiencing addiction, treatment and illicit drug use also accumulate, and so we show these in boxes. The oval circles represent levers, essentially regulating the amount of accumulation. So for example, the amount of illicit drugs that are available, which we know was increasing in the county at the time, regulates the amount of drug use that exists. More supply equals more use. Similarly, the amount of treatment programs that people can actually access regulates the number of people in treatment. And treatment's the key. As you can see from the slide, it stops the high mortality system. However, illicit drug use leads to overdose and death, and it reinforces high mortality. So we can focus interventions at this area on overdose. And again, we know these accumulations are taking place specifically with arrest and prison because our task force partnered with police and courts. So we were able to identify that as a factor. Next slide. Interventions serve as feedback in a system on a stock and flow map. They balance or reverse the system. So looking at the left half of the slide, you can see that iStop was an intervention that came as a result of opioid use accumulations. We show this by that solid black arrow that points from the opioid use circle to iStop. The dotted arrow pointing away from iStop, pointing to the prescription rate, shows the intervention as balancing feedback on the prescription rate. iStop was designed to push this system back and ultimately reduce mortality by reducing prescriptions. And it did reduce prescriptions. But we can also see that it inadvertently drove people to illicit drug use, creating the loop that's shown by the red arrows on the right half of the slide. And you can't see the red arrows, but there we go. Thank you. And so that loop further fuels the mortality rate. Unless something breaks that loop, the system is going to continue to drive mortality higher. Nothing is impeding it or stopping it. iStop also left many parts of the system unaddressed. If you look across the top of the system, nothing is addressing the other parts of it. So iStop alone was not a sufficient intervention. Next slide. The task force intervened at multiple points with an opioid crisis hotline, treatment clinics, provider education, and naloxone or Narcan to reverse overdoses. And they funneled as many people as possible into treatment, which we know stops the system. The bold dotted arrows show those points of intervention. Tools like stock and flow maps and feedback loops can help us understand complex issues. And in class, MPH students build out stock and flow maps for issues such as climate change or primary care access, really any public health issue, because it helps them to see multiple pathways and many causes and effects that contribute to some of the major public health challenges that populations face today. Next slide. This case also demonstrates the competency of coalition building and partnerships, number 13. The county collaborated with multiple sectors of society in creating the task force and its 7 committees, and it empowered them all to act as they needed to address priority areas. You can see on the slide the many different groups that contributed to the effort and ultimately influenced the outcomes. Next slide. The discussion questions for this chapter really take key points from the case in a way that tries to reinforce with students that not one specific factor and not one specific intervention, for example, iStop, was the key. Rather, all levers of the system, all committees on the task force, and all programs and interventions essentially work together to balance the system and reverse that high mortality trend. So the key with these discussion questions is to hopefully have students pull that out from the case itself. So thank you for listening to the case, and now I'll turn it over to Dr. Chris Wickman, who will present the next case.
Thank you, Kim. I'm going to be presenting the overweight children analysis of 3 interventions in reducing BMI Z-scores, and I would be remiss if I did not mention my 2 co-authors, Dr. Lynette Smith and Dr. Paul Estabrooks, both of which are University of Nebraska Medical Center College of Public Health. Next slide, please. So the background for this is that childhood obesity is at epidemic proportions according to the World Health Organization and the CDC. And childhood obesity has well-documented relationships with reduced physical, social, and psychological health, and it also predisposes these children to have experienced chronic diseases as adults. And some of the chronic diseases are listed here as cancer, diabetes, cardiovascular disease, and non-alcoholic fatty liver disease. Other studies have also shown that childhood obesity or overweight children are also linked with being either bullied or becoming bullies, and also having low self-esteem. And you can see here in 2016, based on NHANES data, there's about 33% or a little over a third of children aged 2 to 19 in the United States are classified as either being obese or overweight. Next slide, please. So again, the US is not alone. The World Health Organization identified childhood obesity as a serious public health challenge. And this is very evident in the fact that 54% of reporting countries have obesity rates or overweight and obesity rates of greater than or equal to 20%. In fact, the WHO actually estimates approximately 340 million children aged 5 to 19 are either overweight or classified as obese, with at least 41 million being obese. And then 1.9 billion adults worldwide, 650 million of which are obese. So this all comes to a head in that obesity accounts for between 2 to 7% of all healthcare spending in developed economies, or basically 3% of the gross domestic product. Next slide, please. So in this case study, it's a randomized controlled trial. It was registered, and it was a private healthcare system was the actual setting, and it was a set of health promotion researchers that approached this private healthcare system to try to look at an additive intervention that could curb the overweight and obesity in adolescents. So it's a longitudinal study. They took measurements at 0, 3, and 6 months. And the novelty of this particular intervention is that the unit of randomization was a parent-child dyad. In fact, the intervention was done with the parent themselves, and if there happened to be multiple children in the family, one child was randomly selected to be the quote-unquote measurement child. Although all children were measured, only one was actually retained for analysis. And the primary outcome measure that they chose was the child's body mass index Z-score. And the reason they chose this is that if you look just at a change in weight, you're not accounting for how quickly a child may be growing. So we look at BMI to account for height, and then we use the Z-score to account for age and gender differences. Next slide, please. So the 3 levels of the intervention, the first group would be this family connections workbook only, and I'll discuss that in just a second. The second group would receive this workbook plus 2 small group sessions where they get together with other families and they discuss how to be healthier, I guess is the best way to put it. And then the third group was this workbook plus some small groups, but then they also had 10 interactive voice response phone calls. And later on in the intervention, they actually tailored back and decided that 6 interactive voice response may be better. The workbook itself came in 2 parts. The first part was an assessment of the home environment, looking specifically at influences on eating and the activity levels of the children. And then the second part was looking at how could you implement change within the home environment, and then also had a section that focused on parenting skills. Next slide, please. So the analyses here used a generalized linear mixed model, and they also used the intent to treat principle. So if you were randomized to a group, you were retained for the analysis. Overall, results show that in all 3 groups, there was some decrease in BMI Z-score for the measurement child. The decrease between baseline and 12 months was noted in the workbook only group. The second group that also had some small groups saw a change between baseline and 6 months, but this could not be sustained at the 12-month mark. So basically it looks like a V shape as far as the average BMI Z-score. And then the last group that also had the interactive voice response, they saw differences between baseline and 6 as well as baseline at 12 months. But then when you went to look across all the groups, you could not detect that any one group performed better on average. Next slide, please. The summary points of this particular case study is that it's a longitudinal randomized controlled trial. The overall goal was that it was to look at the efficacy of a scalable additive intervention to address the childhood and overweight obesity epidemic. And what they meant by scalable was how quickly could it be pushed out to multiple locations. And the additive piece was that, if I give one group the work, I can do the workbook with some people if it indicates that. I can do workbook plus some small group, or workbook plus small group plus the interactive voice response. It did have a non-traditional design. Again, the parent-child dyad was at the time relatively novel. They did go through and do some pre-planned secondary analyses that I don't discuss in my slides here, but is discussed in the case study itself, where they generated some alternative hypotheses, in case the BMI Z-score data was not, did not show any differences. They had other things that they had pre-planned ahead of time so that they knew what their method of attack was going to be to look at this data. And the other novelty here is that this was a private health system where a group of public or health workers, specifically in health promotion, teamed up with the health system to try to push an intervention into a more mainstream, everyday kind of clinical setting. Next slide, please. So this case study actually applies to about 3 competencies. The first competency is the quantitative and qualitative data collection methods appropriate for a given public health context. Again, here they use the primary outcome of BMI Z-score. The reason they chose BMI Z-score, again, was we were talking about adolescence, so you have to account for the fact that the child is growing during this entire time, so their weight's going to be changing just due to growth, if nothing else. So they chose the BMI Z-score because it was the best measure in their mind as far as capturing true changes within a person. They also had the secondary outcomes. Again, this was the secondary piece that they had alternative outcomes to look at that actually measured physical activity, eating habits, eating disorders of the children, and these were all collected via validated self-report questionnaires. And then they also had a qualitative data piece where they gathered data using research field notes, and they reduced this into themes to look at quality improvement. The second competency that we looked at were analyze quantitative and qualitative data using biostatistics, informatics, computer-based programming, or software as appropriate. So in this particular study, they use SAS statistical software, although SPSS, R, anything could have been used. And then from the qualitative side, they used branching tree logic to assess their qualitative data. Next slide, please. And then the last competency that's covered is that in the interpretation of results of data analysis in policy or practice. And in this case, the comparisons were made baseline out to each time point and then also across groups. They went back and looked at, basically did a self-reflection and determined that future research was needed to determine the frequency and duration of the interactive voice response contacts to achieve the optimal decrease in BMI Z-score. And eventually, again, like I said, they went from 10 down to 6. They thought 10 was too, people basically gave feedback that 10 was too intrusive, and 6 seemed to be kind of the perfect number, at least within this cohort. And then the study also demonstrated that researchers can partner across different types of healthcare systems, across academia, basically kind of going along with the theme of getting everybody, to get into the buy-in and try to make ourselves healthier. Next slide, please. And then these discussion questions are just an example of what you can do. I kind of wrote these to look at, have the students define what does it mean to be scalable, what are we after in general, looking at the additive levels of the intervention. Does that mean it can be moved from any state within the United States? So basically getting at the inference space. Also looking at identifying how this idea of the IVR contacts, what can explain, why would an IVR contact help decrease BMI Z-score versus the small group only kind of thing. And then just getting into some other questions about design and analysis. All right, well, thank you for listening to my case study, and I will pass this on to Dr. John Beard.
Thank you, Chris. I'll start by acknowledging my co-author, Dr. Chantel Sloan, here at Brigham Young University. The title of our case study is Designing Policy to Reduce Particulate Matter Air Concentrations in Cache County, Utah. Next slide. Exposure to small particulate matter air pollution, or PM, can adversely affect human health. Children, the elderly, and individuals with cardiovascular or respiratory conditions are most affected by exposure to PM. The U.S. Environmental Protection Agency, or EPA, sets health-based standards for 6 different air pollutants that each state must meet. One of the air pollutants for which EPA sets standards is PM less than 2.5 micrometers in diameter, or PM 2.5. PM 2.5 is of concern for health because it is small enough to enter the alveoli in the lower lungs where gas exchange occurs. It can also cross into the bloodstream. 2.5 is primarily composed of fuel combustion products, road dust, and crustal materials. Next slide. Our case study takes place in Cache County, Utah. Cache County is located about 80 miles north of Salt Lake City along the Utah-Idaho border, as shown by the red box in the map on the left. Cache County is located in a large valley that is surrounded by mountains. As such, it is susceptible to temperature inversions during cold weather. Typically, air cools as elevation increases. During a temperature inversion, however, this pattern is flipped and warm air aloft traps cold air beneath. As shown in the right, this warm air layer, in conjunction with the mountains that surround the valley, creates a bowl with a lid that traps air pollution in the cold air layer near the valley floor. Temperature inversions can lead to levels of PM 2.5 that reach 3 times the EPA limit for a 24-hour period. Next slide. So Cache County officials suspected they had a PM 2.5 problem, so they began monitoring PM 2.5 levels in the year 2000 using stationary monitors that provided continuous measurements. The figure shows the PM 2.5 data they collected from 2000 to 2006. PM 2.5 levels are shown on the vertical axis, whereas the date is shown along the horizontal axis. The 24-hour mean PM 2.5 levels are shown by the connected black dots. Until December 2006, the EPA limit for 24-hour mean PM 2.5 levels was 65 micrograms per cubic centimeter of air, which is shown by the blue small dashed line. In December 2006, however, the EPA limit was lowered to 35 micrograms per cubic centimeter of air, which is shown by the red large dashed line. Cache County sent their collected PM 2.5 data to EPA so EPA could determine whether Cache County had attained the new desired PM 2.5 levels. Next slide. In 2009, EPA declared Cache County in non-attainment of the new PM 2.5 standards, so they were too high. Cache County delegated authority to mitigate their PM 2.5 problem to the Bear River Health Department, which is located in the county. At this point in the case study, we introduced Josh Greer, Environmental Health Director of the Bear River Health Department. Josh worked with statisticians to determine the largest sources of PM 2.5 in Cache County and learned that about 50% of PM 2.5 emissions came from motor vehicles. Although EPA does not require motor vehicle emissions testing, Josh and his team decided that motor vehicle emissions testing would need to be part of the plan to reduce PM 2.5 levels in the county. Not all members of the county council and public agreed, however, and an ordinance that would require motor vehicle emissions testing failed to pass the county council in 2012 because of concern regarding the burden of regulation. After much discussion, the ordinance passed the county council in March 2013. Motor vehicles 7 years or older would have to undergo emissions testing every other year. 3 types of emissions tests would be used depending on the type and weight of the vehicle. Next slide. Emissions testing officially began on January 1st, 2014. Other efforts to reduce PM 2.5 levels were also implemented. For example, there were efforts to reduce emissions from paint, newer vehicles with better smog ratings became available, new fuel standards were implemented, and there was an increased effort to reduce vehicle idling. PM2.5 levels were monitored over the next few years to determine whether the new policies effectively reduce PM2.5 levels in Cache County. The top table shows summary statistics for 24-hour PM2.5 levels in January and February of 2014 to 2017. The table is actually just showing a subset of the statistics that we show in our case. The bottom table shows age-adjusted rates of emergency department visits for asthma and myocardial infarction or heart attacks in Cache County in 2006 and 2014. Although not shown on the slide, our case study also includes data regarding the total number of motor vehicle emissions tests and failures for different vehicle types in Cache County for 2014 to 2017. Although initial evaluations of the effectiveness of the PM2.5 policies were mixed, the policies need to continue to be evaluated to determine whether they are having a positive impact on PM2.5 levels and health in Cache County. Next slide. To summarize, small airborne PM is dangerous to health, especially for people with pre-existing health conditions, the very young, and the elderly. Cache County collected air quality data to determine if they had a problem with PM air pollution. Using these data, EPA designated Cache County as in non-attainment of their PM limit. The Bear River Health Department used the air quality data to develop a motor vehicle emissions testing program, and they continue to use data to evaluate the effectiveness of their program. Next slide. The CEIF competency that we wrote our case study to address is competency number 4, interpret results of data analysis for public health research, policy, or practice. Ideally, public health policies are developed because a weight of evidence suggests the policy is needed and will be effective. Policymakers should understand how to read analytic results such as tables and graphs and draw correct conclusions. They should also understand how to identify limitations of certain data, what biases influence collection and analysis, and what factors may confound results. Students who become fluent in reading analytic results will be able to make policy-level decisions that are more beneficial to more people. Students will also be able to explain results of data analysis to policymakers. Next slide. Different entities may view the same data differently depending on their goals and values. If the scope and limitations of data are not explicitly communicated, then decision-making can be misled. Students must be able to ask objective questions about data sources, collection and analytic methods, and presentation of results. As policies evolve, they must be continually evaluated. Students need to be able to ask questions regarding data that are presented to them so they can move projects and policies forward in positive directions that continue to be based on evidence. Next slide. Questions about our case study that can be used to help students achieve the desired competency include the following. What was the main issue Josh and his colleagues were trying to overcome? What role did data collection and analysis play in determining whether Cache County had a particulate matter air pollution problem? What role did data collection and analysis play in the development of Cache County's motor vehicle emissions program? Based on the data, was the program effective? Why or why not? Data could Josh and his team collect to better understand the strengths and weaknesses of their program, its overall effectiveness, and potential changes, if any? Of course, several more questions could be used. Next slide. I'll now turn the presentation back over to Anthony.
Thanks a lot, John. So as you all have heard, these are a sample of the cases that are brought to you in this book, Master of Public Health Competencies, a Case Study Approach. If you go to the next slide, you can just see some of the highlights. As we all know, about a year and a half ago or 2.5 years ago, CEIF released new competencies that accredited MPH programs must adhere to, and the 22 chapters of this textbook are aligned with the 22 required competencies. And as you heard from several of the case studies just presented to you, many of the case studies cover more than one competency. The breadth and depth of topics cover beyond just the 5 key disciplines of public health, but really we're talking about everything from asthma to Zika. And the cases are written not only by public health faculty, but also in some cases with or co-authored by community practitioners. And so we think the depth and breadth of the topics, along with the fact that they're aligned with the 22 CEIF competencies, make this a really rich text that can be used in the classroom. I did just want to mention, I alluded to earlier that those of you, who registered for today's webinar, answered some questions about your background and what levels of education you teach, and where do you see a textbook like this could fit in your respective curricula. And with that specific question, we got a whole host of responses, everything from introduction to public health classes to discipline-specific classes like epidemiology, biostatistics, etc., to things related to seminars, culminating experiences or applied learning experiences, integrated learning experiences, specific case study courses, team taught courses, individual taught courses. We really saw virtually any kind of course that could be potentially offered in an MPH program. So I urge you to kind of give this some consideration. And if you go to the next slide, you can see that you all can feel free to request a review copy by going to the Jones and Bartlett Learning website. And you can even speak to your respective Jones and Bartlett sales reps about creating your own custom books, which basically allows you to take material from more than one text and combine it to create a customized text for you to address the respective needs of your class.
Thank you everyone for joining us today and for all of these thoughtful questions and comments. And a very special thank you to Anthony Santella, John Beard, Kim Curtis, and Christopher Weichman for your excellent presentation. If there's anything that you have questions about from here on in, please feel free to email me. And with that, I'd like to conclude today's webinar. Thanks again, everyone.